We work in a group of 6 community oncologists, and most of us have largely adopted a change in practice in the last year or so, where now we tend to start with afatinib as our first-line agent. We do always have some concern about diarrhea and toxicities, and often we will often choose to start in the beginning at least at a 30 milligram dose and work up at the first opportunity, even within the first 1 month. And having done that, we've actually found it quite deliverable and manageable, but we have made a big change to using afatinib in more patients. LUX-Lung 7 was a randomized phase 2 study. It was not a large study, but it asked a very important question. It was the first study really comparing 2 EGFR inhibitors head-to-head. It was long awaited, and I think we awaited the results of the study with some concern that maybe it would not be powered enough to show meaningful differences. And I think we were quite surprised at the results. It was a very clean design. It was a very pragmatic study comparing 2 drugs at the usual indicated doses head-to-head, asking an important question. It was fairly inclusive of patients of both types of common mutations, the deletion 19 and the L858R. So it really answered a lot of questions about how do they compare in terms of toxicities in a real-world comparative setting, and how do they compare also with respect to different kinds of mutations we see. Gefitinib has been more or less our go-to first-line drug in Canada prior, and I think in many parts of the world. So it is a very relevant comparison for our Canadian marketplace. Erlotinib tends to have been used more in Canada in the second-line setting in unselected patients. Head-to-head trials should be the main type of trial we see, when really trying to answer a question. It's very difficult to do cross-trial comparisons when you have an important, relevant issue in practice. So I think head-to-head studies are very important and probably not done often enough. Progression-free survival is not the endpoint that clinically is the most meaningful to patients. Progression-free survival usually means that the scans look prettier for a bit longer. However, as we know, we're faced with real challenges in real-world trial design showing overall survival because of subsequent therapies, for example. So it's very difficult to show overall survival in standard trial designs. So we have come to accept PFS as a meaningful endpoint. And when the difference in PFS is really of a certain magnitude where it can drive us to, to believe it's meaningfully important, it is enough to change our practice. This is an important point. Many oncologists historically would tell patients, based on the median difference in survival or PFS, that if you take this drug or that drug, it'll buy you an extra, month or 0.1 of a month. And this really is a very good example of how we shouldn't say that. The median difference in PFS is really a statistical mathematical number, but we really have to look at the overall shape of the curve and the hazard ratio to really get a good feeling for how they really do comparatively. I like using, for example, the landmark analyses where you look at the 1-year PFS, the 18-month PFS, to really tell a patient in plain English, at this point in time, your chance of being progression-free is this much better. It makes more intuitive sense to patients than saying the median is so much longer. As we see drugs now, too, where we see a tail on the curve or separation later in the curve than we used to see, especially with immune checkpoint inhibitors, we really have to get away from looking at the median. It's interesting, that the differences become more apparent in PFS after 12 months. That is not unexpected, but it's hard to explain, biologically why, if the one drug is better than the other, why it would take 12 months to see that. However, the results are what they are, and I think they confirm our suspicion earlier that a more potent, irreversible inhibitor might be better. Time to treatment failure, it may be a more pragmatic endpoint than PFS, because time to treatment failure includes things like discontinuation for toxicity or for other reasons the patient may choose to stop therapy. The real drivers of why patients start or stop therapy are included in that, including death or disease progression. They're all wrapped into one. So it really is a much more, I think, pragmatic, digestible endpoint for patients. Yeah, I think the time to treatment failure, it is a sort of a combination endpoint of progression enough to take someone off therapy, also toxicity that was not manageable for patients, or patient preference. So it really kind of encompasses all of the pragmatic different reasons someone would stop a therapy, again, in a very pragmatic way that I think we can take home, and that will reflect on our patient care in the clinic. It's hard to comment on the meaning of the overall survival data we've seen so far. I think it's just not mature enough. The trend, the confidence interval leans more towards favoring, the afatinib. However, it may be underpowered to show significance. Objective response rate is something, again, we teach residents and students not to go by. It really means how a scan looks, how much better a scan looks compared to before. The primary endpoints in palliative therapy for cancer are survival and quality of life. However, in lung cancer particularly, the response rates can be meaningful because patient pain, for example, bleeding, impact on breathing, if there's a bronchial tube being blocked, really can vary directly with the size of a tumor. So if you have a good response rate or a rapid response, it can meaningfully translate to symptom improvement in our patients fairly quickly. I think quality of life, particularly in a non-trial population, in a real-world population of patients, is as important, if not more important, than survival. If survival is doubled or tripled, that may change the equation. But for most palliative cancer therapies, quality of life is very, very important to patients when you ask them. Quality of life to patients, however, is always a balance of toxicities and cancer symptoms. And they often tend to see the toxicities right away, and they don't often see in their mind what the symptoms of the cancer would be, down the road if they weren't on therapy. So having real quality of life data from a well-designed trial to show a patient is very helpful in convincing them to buy into a therapy. Yeah, the LUX-Lung 7 study, I think, confirmed the side effect profiles that we expected from our previous trial data. So it was nice to see that. It was also nice to see that the grade 3-4 diarrhea was quite minimal. It has been improving in every sequential generation of study with afatinib, from high numbers in the beginning to around 6% later in the Asian trials, and now to quite manageable small numbers. And I think that probably reflects increased experience both with the drug and increased experience for oncologists dealing with diarrhea generally. A lot of our drugs now cause diarrhea, and I think our teams, our nurses, our pharmacists are getting better at handling it. Diarrhea can be really difficult. Paronychia, I think we're learning how to deal with better. Right now we have a lot of anecdotal evidence. The rate of interstitial lung disease from gefitinib and the liver enzyme changes were pretty much in keeping with what we've seen before. Again, I think when you look at a clinical trial population, they tend to be more educated, perhaps more healthy, maybe somewhat younger than a real-world population. So if we were to extrapolate the conclusions from the study to a real-world population, maybe older patients, cultural, language barriers, I would tend to be a bit cautious, at least with the dosing, if we're not in a rush to get a rapid response. My partners and I often start at 30 milligrams of afatinib, for example, and work up to 40, even within the first 1 month, to make sure we are comfortable with the patient managing well. If they have more diarrhea, it becomes grade 2, 3 on 40. The patient will then remember that they did pretty well on the 30, and they'll feel comfortable going back to that. Whereas if they start off, and again, a real-world patient population, if they start off at 40 and have grade 3 diarrhea, it's very hard sometimes to convince patients to continue on therapy. I think the major strength of the LUX-Lung 7 trial has to do with its very clean design, a very pragmatic question, and the fact that it's a head-to-head comparison. The LUX-Lung 7 is asking somewhat of a different question than LUX-Lung 3 and 6 because it's really comparing, two EGFR TKIs as opposed to comparison with chemotherapy. But it really helps us, I think, better place the role of afatinib compared to other available agents. With LUX-Lung 3 and 6, we saw clearly, survival benefit. With afatinib, we saw it's better than chemotherapy in patients with relevant mutations. But we're forced to do cross-trial comparisons trying to pick out which EGFR therapy to use. And now we have some direct head-to-head evidence to, again, really comment more on toxicities comparatively and to compare the efficacy more in a head-to-head fashion. I think the main take-home message is that we do confirm efficacy of afatinib. The efficacy, the side effect profile is what we expected it to be. And even though we had expectations, perhaps, the two drugs might be equivalent, frankly, it does confirm that maybe a more potent permanent inhibitor of EGFR may actually achieve better long-term outcomes for our patients on therapy. I think it'll validate our selection more nowadays of using afatinib as a first-line agent until we have the next third-generation drugs down the road. The LUX-Lung 7 results, I think, will again validate our current clinical practice of using afatinib first line. In patients with the L858R mutation as opposed to deletion 19, I think there was some uncertainty. Maybe is chemo better? Is chemo just as good, even though the oral therapies are better tolerated? And I think actually seeing the waterfall plots from LUX-Lung 7 confirmed also that in the L858R patients there's meaningful benefit, fairly rapid benefit, and may help reassure us that we can use these drugs effectively in that population. Yeah, I think that we should all be pretty much on board now with mutation testing in every patient we're treating with non-squamous non-small cell lung cancer. The processes have become more automated, more involving reflex testing across Canada, but not uniformly. I think having this kind of data confirming that we have effective drugs and even more effective drugs should help push for reflex testing now across the country.